Good evening and welcome to Unlocking the NHS, chaired, as you can see, by my good self, Alastair Stewart. A number of you, I hope, will recall my days at ITV News. My academic background is as an economist, and my greatest physical skill is the ability to listen and try to understand what other good folk are saying. We have a phenomenal panel lined up for you tonight to discuss the changes that have happened within healthcare provision within the NHS as a direct function of the challenge of COVID-19. We'll analyse some of those challenges. We'll talk in great detail with the experts in their fields about what they've done to find clever and better and smarter ways of dealing with a once-in-a-century challenge. But also tonight, we're very, very keen in hearing from them and indeed from you, and over 800 of you have registered to listen to this conversation, to contemplate that period where post-COVID-19 at its worst, we can begin to think, what have we learned from that crisis that may be durable and make the great NHS even better? That's very much at the heart of it. Also, the very fact that we're talking to you tonight via Zoom, and a technology that has suddenly rocketed during this crisis because we can't all gather in a lecture theatre as we might normally have done. We'll be looking very closely at the whole role of digital and how that can be further enhanced. I know it's already incredibly important, but is there even more that we can do? This is something that was born as an idea just 7 weeks ago by my good friend David Harkin and others. David runs 7 Billion Ideas, and this is just one of them, and it is truly phenomenal. The theme, the vehicle for it is WeShare.Healthcare. It's a collaborative, non-political, and certainly not for profit forum for health practitioners. We're keen to promote collaboration, as indeed are they, during COVID-19 and afterwards. The panel that has been assembled tonight is truly remarkable. Leading figures from the management of the NHS itself, the Royal Colleges at very, very senior levels, the BMA at a very, very senior level, frontline practitioners, the bulk of whom operate at the top of their professions, and as I said, many of you, and you may tick those boxes or others, but you are most welcome. The structure of the evening is very straightforward. We've invited some of those top people to give you short, sharp presentations of how they see things right now, either as an NHS manager or anaesthetist or general practitioner or physician or surgeon, to give their views. We've got a couple of broad macro background pieces, not least from Baroness Camilla Cavendish, who wrote a brilliant piece in the FT back in April, precisely about what we're talking about tonight. We've got some case studies that we will examine, and the authors of those will be open to direct questions by you, the people who've been kind enough to join us tonight. And then we hope at the end of the evening, towards 8:30, 8:45, we will be able to protect about 15, maybe even 20 minutes, if my good panelists all behave themselves, where you can send in your questions via this Zoom, and you know how to do that, I'm sure. It's there along the side, and I will be monitoring that, and my colleagues at WeShare.Healthcare will be monitoring it, and I'll say, look, so-and-so from Huddersfield or somebody else from Manchester wants to ask X, Y, or Z of a particular panelist, or just make a general comment because they've had a brilliant idea that they want to share with you. So I hope that that is pretty straightforward, and that you would enjoy it, and that you will learn from it, and that you will certainly participate in it as much as possible. We're going to record the whole thing, and we're also going to take good notes, so that it isn't just another talking shop. It really is a hands-on, practical, logistical exercise in how we can improve the service to people at the moment from the NHS in the context of the crisis, and how we can do things even better after that. So I mentioned David at the beginning, and I'm delighted to mention now Ryan Kerstein, who's a plastic surgery registrar in Oxford and the other co-founder of WeShare.Healthcare. And I'm going to invite Ryan now to spend a couple of minutes just telling us a little bit more about what this brilliant initiative is all about. Ryan.
Thank you very much, Alastair. Good evening, ladies and gentlemen. On behalf of the WeShare team and our partner 7 Billion Ideas, thank you very much for joining us this evening for what should be a fascinating discussion. As a group, healthcare professionals, we're pretty good at problem solving, from making the hard diagnosis to choosing the right operation, or in the era of COVID, implementing the new way of working or developing the new digital innovation to streamline our work. We also pride ourselves on our communication skills with our patients. But often our communication skills with one another gets forgotten. We develop these great innovations, but forget to share the initiatives with others. Most of the time, the challenges we face are common, and therefore the process or invention that you've developed or adopted, however small or big, would just be as useful for the hospital on the other side of the UK or the team down the corridor. There's no point all of us spending our valuable time trying to separately crack the same problem. So this is why a group of us from across specialities came together to create WeShare.Healthcare. Our site is a free-to-use innovation hub where healthcare professionals from any discipline can both upload and share innovations that they've been using, but also search for solutions that others have adopted. So just to give you a couple of examples that have already been put on the site, Process C19 from the Royal Free Hospital. This is a not-for-profit group who have partnered with hotel chains who obviously aren't letting out their rooms at the moment, and they've been able to deliver 30,000 hotel rooms across 550 sites to be used for rehab beds for post-COVID patients, cold outpatient services, and step-down facilities. Or Teacup, which is a free-to-use tool for healthcare professionals to help with their own well-being during the pandemic. Or Snap, which is a device that clicks onto any conventional surgical mask, creating a valved hole, which a clinician can then pass an endoscope through, protecting the other people in the room during this high-risk aerosol-generating procedure. So, I'd implore you all, after the summit, to head over to WeShare.Healthcare to share the new ways of working that you're using and to see what others are doing. You can literally upload your idea and find someone in just a few minutes. So to conclude, from our point of view, we want you to share big, share quickly, and share now. The only thing we don't want you to share is COVID-19.
Ryan, thank you very much indeed for that crisp analysis and that very good cautionary instruction at the end. David Harkin, I mentioned in passing at the beginning, but interesting, Ryan talked there about digital innovation and communication. David is a master of these 7 billion ideas. One of them is about how we can use digital technology to share ideas, and as he describes it, the theory of relentless innovation. So we've invited David to talk to you for a couple of minutes to explain precisely how he believes his philosophy can make the NHS and its provision of services to the good people of this country even better. David.
Alastair, thank you very much, and thank you, Ryan. It's a pleasure to be here. My name is David. I run an organisation called 7 Billion Ideas, which passionately believes that every single person out there has the ability to change the world and has ideas. We're very lucky that we work in two very different industries. One in education, where we work with students all around the world, encouraging them to think big and to dream big about their possibility of their own ideas. But secondly, where we work with organisations with something that we call Spark, and we've evolved here, organisations which continue or want to become world-class in everything that they do, and really embrace what we call the model of relentless innovation. To us, innovation is 24/7. It can happen any time of the day. Tiny, small and big ideas do really count. What we've seen over the years, though, across sectors, so not just in the healthcare sector, but across and around the world, is that when companies and organizations talk about innovation and they say, look, we do listen, we do share best practices, typically they are doing one of these three things. They might say, look, we've got a suggestion box scheme here. We want to hear the ideas, but these are just not sustainable. And all suggestion boxes do is collect dust. I've yet to meet leaders who don't claim to have an open door policy, which is fantastic, but you've got to have great timing and confidence to walk through that door. And then organizations will create think tanks and opportunities to share ideas, but the problem is that these ideas aren't recorded. And we have a real big challenge as well in this sector at the moment, is that time is precious. But the problem is when we do not share ideas, We cannot be relentless when it comes to innovation. And what actually happens is the Ebbinghaus curve impact kicks in. The ideas are simply forgotten over time. And when we're brilliantly busy, which is a phrase that we love at 7 Billion Ideas, this is accelerated. So the reason we've come together to work with WeShare is to really help evolve our platform, our methodology, to continue to help organisations such as the NHS and all the professions that you'll come from to continue to be world-class. Our theory is quite straightforward on here. We just got to continuously improve in everything that we do, but we should be relentless. But what we cannot do is not share great stuff which is already going on. So with WeShare, WeShare.Healthcare is live now. It's a public platform where we want to see ideas collide and explode. And our philosophy on this is quite straightforward. You know, it might take 90 seconds to log on to a platform like this, and time is precious, but that could generally save lives and make a big impact. So thank you very much for coming along tonight. We look forward, if you would like to learn more about 7 Billion Ideas, please do visit, or if you'd like to get in contact and talk more about this with me personally, I am on LinkedIn, and I hope you enjoy this evening.
That. I just want to remind folk before we go to our first panelist that the chat function is there at the bottom of your screen on Zoom. Do please send in comments. We've already had a few, one about hardware infrastructure and the need for investment in that. And we'll come to issues of that nature a little bit later on. But just, you can ask a specific question when you've heard from the panelists, or you can begin to say, look, I think you should be thinking about X, Y, or Z. Just use the chat function down there at the bottom of your screen. I first became engaged intellectually in what tonight is all about when I read the FT back in April, and the FT columnist Camilla Cavendish, Baroness Camilla Cavendish, penned a piece saying, look, out of the COVID-19 crisis, there are things that can be positive, things that can be developed. And she then penned this very crisp analysis of what we were doing already and what we might do better. And Camilla Cavendish, I've known for a long time, not only as an FT columnist, but she's also worked at the very heart of government as a policy advisor. She sits in the House of Lords now, obviously, and contributes to those debates. But also, apart from a very strong academic background, during that policy role, as it were, her fingerprints are all over things like the sugar tax and so on and so forth. And also she's very interested in care and the crossover between health and care, which clearly is a major issue. And if you haven't read Extra Time, 10 Lessons for Living Longer, then I thoroughly recommend it. So I'm only plugging the article and the book because I've read them both and they are truly excellent. We've asked Camilla to speak to us for 5 minutes about the rapid revolution in the National Health Service that has helped us cope with COVID-19 and what the land after that may look like. Camilla Cavendish.
Thank you, Alastair. I mean, I'm the least expert person in the room, but I'll give it a go. So I guess the NHS is often portrayed in the outside world and by the media as a monolith. And of course, all of us know that it isn't. It's this unwieldy mass of different organisations going at different paces. And as Ryan said, you know, sometimes reinventing the wheel, quite often, you know, huge variation across the piece, and we don't always share properly. I think what's happened in the last 2 months is something I could never have predicted, which is that Simon Stevens, NHS England, and a lot of individual clinicians have taken back control, if you like. And I think a lot of the changes that we've seen are to do with breaking the rules in a number of very positive ways. I mean, I'm sure there are less positive things. I mean, I'm sure that in some cases, patient to staff ratios will have gone below what we would all like to see, for example. But there are quite a lot of things that I've found encouraging. And it's not just the Nightingales being built. It's also things that really do require breaking the rules. So for example, the redeployment of staff. I'm talking mainly about hospitals here, but I mean, you've seen dentists becoming respiratory nurses. You've seen healthcare assistants and indeed care workers in social care, who are two groups that I've studied a lot, actually really stepping up and starting to do procedures which some of them have been quite scared to do, but in fact, they're pretty good at. And we haven't let them do that before. We've seen hospital discharge, of course, speeded up enormously. I mean, the fact that we've been able to empty the hospitals would have been 2 months ago still thought impossible. In fact, at the end of the day, the deal has been done with social care. The NHS has block booked beds and we have discharged huge numbers of people. That, by the way, will not be sustainable unless we have a better funding settlement going forward for social care. But that is really, really fundamental because, of course, it's relieved some of the pressures on the NHS that also could be pressures in the winter if we don't repeat the feat. The online consultations and the digital revolution, I think a lot of other people are going to talk about, but it is for those of us who are patients who still worry that we're going to end up in hospital when the GP records are stuck in their office in a filing cabinet, is very welcome that we've had this digital revolution. And overall, I think the main thing that hits me is the level of collaboration. So I think going forward, really this is about getting rid of the 2012 Act, or at least the competition provisions in the 2012 Act. I mean, it seems to me people have just bust through those provisions. So in places like Greater Manchester, you're seeing really, really important integration now in all sorts of ways between health and social care. We're seeing partnerships all across the piece between private and public sector, between individual hospitals, between all sorts of different groups, community groups, which I think we need to build on. Fundamental for me, because I used to sit on the board of the Care Quality Commission and worry about this a lot, is paperwork. It seems to me that the paperwork burden in the NHS has become just out of control. And one of my best friends, who's a critical care nurse at Imperial, told me of going down onto the ward, you know, in part of the crisis when there wasn't enough PPE and people were feeling pretty grim. And she said, yeah, but guess what? We're not going to have to fill out all the assessments. And there was this cheer that went up. So I'd love to hear what people think about which assessments are worth doing and which have just become pieces of paper, which is what, by the way, we saw in mid-staffs. We saw people pushing paper and not looking after patients. And I'd only make two more points, I suppose. And Alastair, you're right. I am very concerned about obesity. I've written about it. I was the author of the sugar tax. We are now seeing worrying links between obesity and chronic disease and COVID. And I would really hope that out of this, we can see a revolution in prevention. But I'm going to be honest, that's going to mean GPs actually taking it seriously and actually being willing to raise people's weight with them. I think that sometimes, if I may say so, doctors, clever doctors, get very excited by gizmos and genomics and brilliant cancer drugs. And sometimes basic weight loss control programs are slightly less sexy, but I would really love to see us accelerate those. And the last thing I would say, which again I'm really hopeful for, is that perhaps out of this crisis, will we see people take more responsibility for their own health? I think we all want people to take more responsibility, and I hope this crisis might be a way of doing that.
Camilla, did you think at some stage that the 2012 Act was a good idea? I'm asked by somebody who sent a message in. Or
no.
You always thought that notion of competition was destructive rather than constructive?
Yes, and I was a journalist on the Times at the time and campaigned against it and actually tried to talk David Cameron out of it. So I have never thought it was a good idea.
Fine. Okay. Thank you very much indeed for that. I will come back to you later on, I'm sure, because I've got several questions that have come through. But as I said at the beginning, the key thing now is to get the panelist views out there. You made reference there to the redeployment of staff, but you started off by saying essentially that the rules had been broken, that the NHS was functioning in a different way, almost a sort of UDI from Stuart Stevens and his lead team. Well, I'm absolutely delighted that our next speaker is Professor Chris Moran, who's the Deputy National Strategic Director to NHS England for the COVID-19 incident, and is going to talk about the current situation, and as I promised at the very beginning, crucially, the near future. Professor Chris Moran.
Hi, thank you, Alastair, and good evening, everybody. My name's Chris Moran. I'm a trauma surgeon by trade. I only gave up operating 2 months ago to join the national effort against COVID, but normally I'm a frontline surgeon, still do on call. I'd like to start by thanking every single person who's at the front line and on this call for all the work that's been done. We've heard about the innovations, but we mustn't forget that the care of the patients has been at the heart of everything. So I'm hugely appreciative of what's happened. We've heard already that we are seeing a revolution. This is a terrible incident, but it is the opportunity of my lifetime and your lifetime to make a 10-year leap forward in how the NHS works. It is an opportunity that we mustn't lose, and is recognised in the NHS at the highest level by Simon Stevens, who has said that we need to capture the beneficial changes and lock them into the system. Because I think what we all have to recognise is that we are facing a future that's different. We need to come out with this with a new NHS and a new way of working. And I think we have to accept that over the next, at least the foreseeable future, we are going to run from being in a pandemic into an endemic. So our different ways of working are going to have to stay with us. So at the NHS Central, we are determined to try and capture the innovations that have taken place, pick the ones that have worked, and then promote them and embed them into the system. Those are really simple words to say in a strategy. When it comes down to thinking about the tactics of how you do it, then it's very complicated. The NHS is an incredibly complex ecosystem. Every little bit can have an effect on the other, and it has huge numbers of different pathways. So we're determined to capture the changes, not just in secondary care in hospitals, but across primary care and also into social care. And it is not just about doctors. There'll be many doctors on this call, but it's about the innovations that have occurred in nursing, the innovations in physiotherapy and occupational therapy, the innovations in pharmacy, the innovations in primary care. It is a huge piece of work. How are we going to do it? Well, we're working on that. There are a number of ways of doing it. The good old-fashioned paper way, the good old-fashioned way of going through clinical networks. I believe that the professional bodies are going to play a hugely important role particularly for the specialties, but in a broader sense, all coming together with the Academy of the Royal Medical Colleges. I think that we're going to explore completely new ways of capturing innovation. We've heard already about the system that's being proposed. We're also looking at a crowd finding web system to try and bring people together, not just to give us the ideas, but also to rapidly evaluate them. And at the heart of all this is we have to connect with our patients and somehow make sure that they're involved in this process as well. So it is a rapidly evolving world. Things that 8 to 12 weeks ago we thought were impossible have been achieved in weeks. We can capture this knowledge, we can embed it. It's absolutely essential that it comes from the professions and all the different people involved in healthcare. But ultimately, the NHS England is where all that comes together, because we need to take your ideas and actually operationalise them. And one of the things I'm really keen about with this whole system is I honestly believe that asking people to review the innovations they've done will help give them a nudge to embed them. So asking people to review it, because I think that just doing that from my perspective and from the Royal College's perspective, it sort of gives them a hidden permission to actually continue doing what they think is right, because that's the way we should do it. And I think that's all I have to say, really. Thank you.
Can I just ask you one headline thing? And I know my trade is terribly guilty of looking for glib headlines, but I was struck powerfully by something you said, and one or two people have pinged me a message about it. Do you rule out the return to the status, the pre-COVID-19 status quo? In a sense, thesis, antithesis, synthesis is now applying, and that we are really looking at something fundamentally different going forward, which Camilla alluded to as well.
So I don't think it's ever possible to turn back time. And if we don't take the opportunity to embed the innovations that everybody on this call is talking about, then that would be a failure. So the NHS will carry on. We will continue, I hope, to provide world-class care for our patients, but I am absolutely certain that we will be doing it in different ways.
I'm grateful for that, Chris. Thank you very, very much indeed. Next to speak is the first of our Royal College people, and I'm absolutely delighted that it's David Alderson, who from the Royal College of Surgeons, President of the Royal College of Surgeons, talking about the direction of travel as he sees it from the surgeon's point of view. Professor Alderson.
Alastair, thank you very much indeed. I think that there's probably three very important strands that we've learned as a surgical community during the crisis. The first, I think, is the enormous interdependence that we have, that surgeons often used to behave in silos, and we realize now, having had to face a completely new disease, how important it is to, as it were, consider the whole patient journey through the system, the involvement in primary care, the hospital sector, and the social care system. So interdependence is the first thing. The second thing I'd say is the enormous adaptability that we've seen within specialties, surgeons becoming nurses, surgeons becoming experts in ventilation, patients, etc. And all of those things, I think, have contributed to really clinician-led change. And I think if there's one lesson that certainly the surgical community have learned from this, is how important it is to take control in order to exert meaningful changes and to be adaptable and to actually deliver better quality care in a crisis situation. As far as the future of surgery goes, then I suppose the crisis has made us realize how important it will be to, if we're to start surgery again in a meaningful way, to separate COVID light, COVID cold, COVID green sites where we have little risk of infection from our COVID positive environments. And there are lots of different models in which we will do that. But the one thing we can be sure of is that the way in which we deliver surgery in the future must be different because of the need for a substantial amount of time in the future to, as it were, modify the way in which we deliver surgical care. I think that if we follow that argument through, then the whole way in which we train surgeons for the future must, as it were, reflect this new system. We may have more hospitals that do nothing but elective surgery and other hospitals that take on emergency surgery and some that do very complex surgery as hubs for that kind of surgery. We'll almost certainly make training more reliant on things like simulation. I think that the greater use of digital technologies in this crisis, even if it's simple things like video conferencing, has given lots of people confidence to adapt and to use new technologies. Things that we were fearful of, I think people will be considerably less fearful of. So surgery is going to change markedly following the restart, and those changes can be, as it were, used in the long-term future of surgery in conjunction with our other colleagues in other specialties with whom we have to work. So I think surgery will be changed and changed forever.
David Alderson, thank you very much indeed. And I noted very clearly what you said about silos there at the beginning too. I'm delighted to say that our next contributor is from the Royal College of Physicians. And Sarah Clarke is the Vice President of the Royal College and past President of the British Cardiovascular Society. Dr. Sarah Clarke, your thoughts?
Alastair, thank you very much. So I'm representing the Royal College of Physicians. It was not surprising to us that within days of COVID-19 surge, the whole of the NHS responded as a tour de force. The members and fellows of the Royal College of Physicians found very quickly that all their annual leave was cancelled and unsociable rotas were drawn up and accepted as inevitable. All our elective work was cancelled, outpatients, investigations and treatments. And alongside this, there was this quiet crisis of Britain's missing patients that emerged, the cancer, the heart attack and the stroke patients, with a 50% fall in A&E presentations. As you've heard, physicians were redeployed. 29% of ours were working outside their specialist area, alongside others upskilling. We've talked about nurses and other professionals who were redeployed as well. And they upskilled to provide care on COVID wards and ITU. The trainees, their exams and rotations have been disrupted. And with a call for retired and finally medical students to the front line, it's been very clear to us that there is a workforce shortage. There was, has been, and remains impact on physical and mental well-being, compounded by many losing colleagues, family, and friends. But every area of trouble gives a ray of hope, and the one unchangeable certainty is that nothing is certain or unchangeable, as JFK said. And during this pandemic, we have worked better together across teams, across departments, across trusts, and across the system. We've been innovative, redesigning pathways, adopting new procedures, passports effectively to work in different trusts, adopting new technologies, remote monitoring, virtual clinics. We've emptied our outpatient department, multidisciplinary team working, and numerous Teams meetings. And as many have said, we don't want to go back to the old ways. But whilst there is overwhelming enthusiasm to embed the change, we need to pace ourselves, as this is a long road ahead of us. So in unlocking the NHS, the Royal College of Physicians believes that a whole system approach is needed to manage the additional demand of those patients who have been on hold for operations and procedures and those that are shielding, those missing patients, the current COVID positive patients who need ongoing respiratory and renal support and rehabilitation, and the future COVID positive patients. So at the college, we've coordinated input from our specialist societies to inform an NHS England gap analysis exercise on the shortfall in time-dependent appointments and procedures for patients with acute and chronic conditions. And this will inform a strategy for the restart of elective urgent elements of the service. But there are a whole range of practical considerations with this. We need a fast turnaround time of the COVID test results for local decision making. We need to consider the feasible size of patient lists, giving the extra time now that's going to be needed to don and doff PPE and clean, and the impact of the ongoing pandemic on access to resources such as imaging, intensive care beds, and COVID wards. But it's not all negative. Unlocking also brings opportunity to embed new best practices which have been accelerated by COVID-19, many of which you'll hear about this evening, and those which have been previously hard to realise, where people have dug in and resisted change. But these must be embedded as services recover. Working with medical specialties and across the Royal Societies, all represented here, and through NHS England and NHSI, and the GIRFT programmes, the Getting It Right First Time programmes, and I'm one of the cardiology leads here, we must embrace the system, looking at how we work with primary care to deliver outpatients and diagnostic hubs in a better way, looking at all our clinical pathways and procedures, rehabilitation, social care, which we haven't mentioned a great deal of yet, but this is all for the benefit of our patients, who I think have a greater respect for the NHS, having gone through this with us. But lastly, we have to have our army prepared and ready. The well-being of our workforce is paramount, but we need to bring forward the NHS People Plan. We need further significant expansion of the medical school places, fast tracking of our physician associate regulation, increased support for flexible working patterns and working from home where appropriate, and recognition of the contribution of international staff through granting of indefinite leave to remain. So let's not limit our challenges, but challenge our limits as we take this long, winding road ahead, and we look forward to the challenge ahead.
Sarah, thank you very, very much indeed. Sarah Clarke there from the Royal College of Physicians. And I am delighted to say that our next speaker comes from the Royal College of Anaesthetists. Professor William Harrop-Griffiths is chair of the Clinical Quality and Research Board of the Royal College. And that point about peer review and making sure that there was more cooperation and collaboration between the disciplines is on the money. I'm delighted now to invite Professor William Harrop-Griffiths to address you all. William.
Alastair, thank you very much indeed. I've been asked this evening specifically not to be partisan and to look to the future, but I make no apology for being a little bit partisan and taking a little bit of a snapshot of the present, much in the way that Sarah Clarke did. It's often said that anaesthesia is the engine that drives surgical care. However, in the last few weeks, this engine has been stripped down for parts to support the critical care of COVID-19 patients. Our trainees, SAS doctors and consultants have become intensivists. Our anaesthesia assistants have become ITU nurses. Our recovery rooms and operating theatres have become temporary intensive care units. Our anaesthetic machines have become ventilators. Our drugs have been used to sedate and ventilate COVID-19 patients. And frankly, no one can really work out what has happened to all our scrubs and syringe pumps. We as a college completely support a return to planned NHS activity and a seizing of the changes that have been forged in recent weeks. There are, however, some howevers involved in this support. There is tremendous variation for readiness across trusts and hospitals throughout the United Kingdom. But we genuinely think that we need to look at 4 issues, of which Sarah has mentioned some, and I will briefly mention. Staff returning from their redeployment need to be both well rested and cannot be pushed too hard and too quickly. Spaces like operating theatres that have been committed to COVID-19 patient treatment have to be repatriated and returned to their normal use. Before we can innovate, we need more basic stuff to do what we do at the moment. I won't go on about the shortage of PPE, only to say it is real and it is still present. But also things like key drugs and anaesthesia and intensive care are running in very short supply. Without adequate reserves and secure ongoing supplies of the stuff we actually need, we're going to find it a little bit tricky, a little bit of a challenge to be able to leap forward. But fourthly, and most important and most relevant to the talk that we're all having this evening, is we need to look at systems. The old systems are just not going to work. We need to completely change them. We need to develop completely new systems and completely new processes. Processes that will protect patients, processes that will protect staff, processes that will increase efficiency and will maintain patient care quality and even, we hope, improve patient care quality. We think that anaesthetists as perioperative physicians are ideally suited to take an overview with others of perioperative pathways and to use this crisis as a tremendous opportunity to work with others and to innovate and transform. Getting back to where we were and going beyond where we wish to be will take time. It will also take money. We as a Royal College has asked the Department of Health and Social Care to create a transformation fund to support this work of innovating, transforming, and even reimagining large parts of NHS services in the wake of COVID-19. We want to innovate, we want to go forward, but unlocking the NHS will take substantial support.
William, thank you very, very much indeed. And just very quickly, because I don't want to sneak over the time, but that last point that you were making, a number of people have already pinged in saying, the truth of the matter is at the front line, we are simply working too hard at the moment to innovate. We are just getting from one phase and one case to the next one. And I merely pass that out there because that is what a number of people have said. Huge number of comments, as well as the pressure on general practice. And I'm delighted to say that we have the perfect person to address you next. Professor Martin Marshall from the Royal College of General Practitioners is the chair, and he is going to address you now. Martin Marshall.
Alastair, thank you very much indeed. So I want to take you back in time to the pre-COVID era, if you remember it. It was a long time ago, and describe what general practice looked like, and then describe how general practice changed during the COVID crisis, and then describe what general practice might look like in the future. So prior to the COVID crisis, general practice was under enormous pressure. Demand exceeded supply, and most GPs responded by working harder. We were also very wedded to the long-established model of largely face-to-face 10-minute appointments, which, whilst we had long been computerized in terms of our records, was quite technology light. Then the COVID crisis hit, and general practice transformed itself in an incredibly short period of time. A relatively small portion of practices used triage prior to the crisis. 100% of practices used triage before. Triage, which helps patients, signpost patients to access the most appropriate services for their need. Prior to the COVID crisis, 80% of consultations were carried out face-to-face. During the crisis now, about 80% are carried out remotely, mostly using a remarkable technology called the telephone, which has been around for 150 years, but sometimes using video consultations as well. We're starting to remotely monitor patients, particularly those in care homes, blood pressure, pulses, oximetry, and such like. Increasingly, we're using technology to improve the interface between general practice and hospital services with joint Zoom-based consultations between GPs, specialists, and patients. We're increasingly seeing general practice getting engaged with a public health model, looking not just at the health of individuals, but looking at the health of communities as well. We're seeing general practitioners engaging dramatically with research agendas, contributing to research studies, improving access to data. And finally, and perhaps highly refreshingly, we've seen a dramatic reduction, as Camilla mentioned, in administrative responsibilities, a reduction in 28% in administrative work, in particular around contract compliance. So dramatic changes in a short period of time. What will the future look like? Well, our role as a Royal College is first of all to identify which of the changes that we've seen are good ones for patients and good ones for the NHS that we want to persist with, we want to embed in the system, but also to identify the changes which were appropriate during a crisis, but we need to push back on and reverse as we move forward. Now, identifying the good and the bad is not as straightforward as it might seem. So if you look at triage, for example, surely triage is a good thing, signposting patients, perhaps, but it does really feel like a production line to many patients, and often it acts as a barrier to those with greatest need who are least able to communicate what they want. Remote consultations must be a good thing, surely, and yet face-to-face consultations provide the essence of what general practice is about: trusting relationships, the use of touch, the ability to understand non-verbal communications. Responsibility for populations also must be a good thing, you would have thought, but sometimes there's a tension between our advocacy of individual need and the needs of wider populations. So I'm not going to pretend right now that I know what general practice will look like in the future. What I do know is the future needs to be driven by a much more open conversation between the public, people who use services, and clinicians who provide services. And that's really what we need to focus on over the next few months in order to embed the positive changes that COVID has led to.
Brilliant. Martin, thank you very much indeed. And right at the very top there, using technology more and feeding back through with research papers from GPs to the collective. You also said that the need to use data and use it intelligently was at the heart of it, which takes us very, very neatly to our next contributor, Dr. Jean Nehme, who's the co-founder of Digital Surgery. We've asked Jean to talk about his views on the adoption of digital technology in the post-COVID age. So whether you knew it or not, Martin, you set him up perfectly. Jean Nehme.
Great, thank you guys for having me. Firstly, I just have to say that I was going to wear a hat, but everyone has great COVID hair. I've actually bought my own clippers and cut my own hair. So I don't know how the panelists have pulled off such great hairdos. But anyway, I'll reveal my awful mohawk. I couldn't reach around the back. So look, I think I've got just 3 very simple points to make. I worked within the NHS. I trained as a surgeon, and during that period of time, like some of the other people on the line, I got involved in, I guess, intrapreneurship at the time, but it ended up being entrepreneurship, right? And the first point I've got to make is that, change within any system always starts within, and it starts with really good leadership. And what that means is that, there's always going to be a couple of people who have got an itch that they want to scratch, or a really bad haircut that they're going to cut themselves. But, there are people within the healthcare service that want to make a change, and those people are currently intrapreneurs. And if you look after those and if you listen to those, then you find some of the solutions, right? So that's point number 1, right? So leadership and allowing people who, who have problems that they want to solve to start kind of solving problems and trying to bring in change. Now, what happened was to us, as a simple surgeon, we had this big idea around taking technology and creating a, almost like a a layer of artificial intelligence within surgery and training computing systems to understand surgery and training surgeons on their mobile devices. And so what that meant, and this is point number 2, is that we couldn't do it just as doctors or, as physicians or people who are clinical, right? So my second point is that healthcare systems need to become more than just people who look after people, and we need to mix the skill sets, and we need to really broaden out who takes part in healthcare. So what you'll see during, before COVID and during COVID, there's lots of engineers and people who are really interested in helping solve problems. And so creating a mixed set of skills. And for us, we built this incredible team of people who, without which we couldn't have succeeded. Getting that mix of people together and creating that diverse set of skills and inspiring people through point number 1, leadership, to solve problems that matter, is my next point. My third point is the environment and the culture, right? Building a business for us and building a solution over the last 5 years was incredibly challenging. I had to leave the healthcare service. I had to quit my job as a surgeon. I had to, raise money and make a ton of mistakes by myself and, meet out all the venture capitalists. And we went out to the US and we made a lot of mistakes. And, eventually we built an incredible business that was acquired by Medtronic. And actually probably one of the most successful kind of businesses in the digital health space in the UK. But that was through a lot of hard work and through a lot of difficulty. And I've seen that environment change. And 5 years ago, it was very different when we started building. And where it is now, I think it's much better, but it can still go along further. And so that culture and that environment of support, of accepting people who can make mistakes, of not holding people back, like fundamentally that needs to be more than just talk, but kind of needs to become part of policy on how we do things. So I guess from my point of view, 3 simple things, right? 1, there are people who want to solve problems. They are currently within the system. They are entrepreneurs. Listen to them and let them lead, let them inspire, right? 2, physicians, nurses, lots of people care about patients. But with COVID, all of a sudden you've had the entire country rolling their sleeves up, delivering groceries, wanting to help. Let people who have different skills come in and help deliver that change and build a diverse team around things. And 3, let's build a framework which is an environment and a culture that allows change to happen and that encourages it, that doesn't punish mistakes, and that supports these teams and these diverse groups trying to solve problems that matter to really become frontline, not just for COVID, but for beyond, right? So those are my points.
Absolutely superb and succinct, Jean. Thank you, Jean. Thank you very, very much indeed. I'm delighted to say now that we are joined by Dr. Alison Pittard. Alison's consultant in intensive care medicine and anaesthesia, and she is the Dean of the Faculty of Intensive Care Medicine. Alison, over to you.
Thanks, Alastair. I'll just share my screen. So it was very interesting what Jean just said. I think it's about turning what we do on the head, and rather than training people to be able to do everything, is actually looking at what skills are required, then look at the people that have those skills, and then perhaps adopting a team approach. And that wasn't what I was going to say this evening, but that's just struck a chord with something that that we've been thinking of in the faculty. As COVID-19 leads to critical illness for an estimated 5% of infected patients, the experience of critical care staff and resources of critical care become pivotal to the management of the pandemic. To date, there have been around 11,000 admissions to critical care in the UK, and most critical care units have been running at twice normal capacity. And the only way this has been possible is due to the cessation of the majority of planned activity, liberating space and staff to support this massive expansion. And I'd just like to take this opportunity to thank everybody out there listening tonight and everybody else that you know that stepped up to the mark to help us, because without working together as a team, mucking in together, we would not have got where we are today. And it's just been an absolute eye-opener the way everyone has worked together. Many critical care staff, though, and other staff are still working significant additional hours or periods on call to manage the current numbers of patients. So just because we're over the peak and things are starting to plateau or indeed come down, there are still staff working across the healthcare sector well above what they would normally do. So as we try to, I can't go to my next slide. So as we try to start reintroducing services, it's important to ensure that critical care has the capacity to support this, not just in physical space, but drugs and consumables and adequate staffing levels that are sustainable for the medium to long term. I think it's going to be very difficult to get back to where we were pre-pandemic, and that may not be the right place to go. But we need to make sure that there's a balance between the return to the pre-pandemic standards and restoring normal activity, whilst at the same time maintaining patient safety and, most importantly, staff health and well-being. As critical care is required for much of the acute hospital to function, we need to ensure it remains resilient to support both COVID and non-COVID activity over a sustained period of time. At the beginning of the pandemic, the UK had around 3,600 adult critical care beds, but not all of these beds were available, partly due to staffing shortages. And in order to meet the demands from COVID, we've had to dramatically change the model of critical care delivery by redeploying non-critical care staff. Everyone's worked tirelessly in unfamiliar environments and in exceptional circumstances in order to care for COVID and non-COVID patients. So although the number of COVID admissions to critical care is falling, there are a significant number of patients whose length of stay is prolonged, and they will still be in intensive care for a long period of time to come. We also remain above baseline occupancy rates of 85%. And that makes the faculty and everyone working in critical care concerned, because as non-critical care staff are redeployed back to their normal areas of work, the expanded critical care force will be depleted. And we're going to need to deliver critical care probably in a number of different sites so that we can separate COVID and non-COVID patients. And that means, although we may be back down to baseline capacity, and we may be back down to normal levels of staffing, we'll lose the economies of scale, and therefore we may not be able to deliver even the baseline capacity. And that needs to be taken into account when we restore critical care, well, acute hospital activity. So I think our surge plans have worked well. A lot of the changes have been done in an ad hoc way, mainly due to the extent of the expansion required. But what we really need to do is to maintain our emergency reserve workforce. We can't lose the skills that the non-critical care staff have acquired. And one of the things the faculty is looking at is how we do this. One simple way may be to change some of the mandatory training that we have to do on an often annual basis, and we can't often see the point of it. And maybe we need to relook at that, make sure that some of the skills that have been acquired can be maintained for future surges or future pandemics. We obviously have issues with staffing, but we can't create highly skilled staff overnight. So maybe what we need to do is to look at new models of care. Enhanced care, which is a level of care between the ward and between critical care, would offer a solution, particularly for patients on a perioperative pathway. It would support the restoration of surgical services. Enhanced care would mean patients were looked after safely. And it would also mean that we wouldn't be dependent on critical care staff for delivery, because non-critical care staff, particularly anaesthetists and surgeons, have the skills and competence required to manage the perioperative patient. So this would take the pressure off critical care. The Faculty of Intensive Care Medicine, along with the 3 Royal Colleges of Physicians, have a guidance document that we were due to publish on the 28th of March, but put it on hold because of the pandemic. And we are just looking at it to make sure that it is COVID relevant. And we'll
Alison,
be
I'm going to have
that.
to ask you to draw to a conclusion, because we're going to fall off the end. Thank you so much.
We will be launching that in the next few weeks. And finally, we need to consider the patients who will need considerable degrees of rehabilitation and follow-up. And again, we'll be launching some guidance on that in the next 48 hours. Thank you.
Excellent. Alison, thank you. And again, my apologies, but I'm trying to keep an eye on the clock and we are slipping slightly over. Our final speaker, before we go into our panel with invited medical professions and start taking some of your questions, I'm delighted to say is the chair of the BMA, Dr. Chaand Nagpaul. Chaand, over to you. Do we have the BMA? Chaand, can you hear me all right?
I can hear you, but can you hear me?
I can now. I'm absolutely fine. My apologies. Over to you, sir.
Fantastic. Well, first of all, thank you very much. And I represent doctors in primary care, secondary care, public health doctors, academics, and across the piece. Delighted to be here. And I think I'd just like to start by saying, let's not forget that we did enter this pandemic as a nation with capacity issues. With record waits for all sorts of treatments, but it was clear we didn't have the critical care capacity compared to many of our European counterparts, and we adapted. We adapted by changing a lot of our hospital facilities, wards, to create that space. We built hospitals within very short spaces of time. We started manufacturing ventilators from domestic suppliers that we had never thought of doing before. And I think that we mustn't forget that whilst we have done all of this, a lot of the NHS has been frozen, and a lot of patients who have not got COVID have actually been put on hold. And I don't think we should underestimate the impact that has had on all of those, that sector of healthcare, the 7 million who are still on waiting lists, and we'll have a backlog we need to address. So we have managed, in one sense, but we haven't, I think, attended to the needs of many other patients. We must go through this by getting proper capacity in the NHS to meet the needs of our population. We mustn't just go back to what we had before. I think the other is that it's shown that in the future, I suspect we're going to need PPE for a long time. This virus isn't just going to disappear by September. You can have other waves, and we need to make sure we have, again, sustained production of domestic availability of things like PPE, because we suffered because we've been reliant on the international market, and something we can learn is we've got to be much more self-sufficient. So PPE will be here to stay. We may have to get used to seeing patients more routinely with masks and other equipment, both in primary and secondary care, for a long time. In terms of innovation, yes, I mean, this has been remarkable. Today's meeting, and so many meetings now are held. I mean, many people didn't even know what Zoom was before. And I just look at the time clinicians spent on traveling to meetings, actually spending 6 weeks arranging a date for a meeting because no one had time. But now we can just, in much more an instant fashion, meet and be productive. And I hope we never go back to that previous way of working. We've certainly learned the potential of remote working, video consultations. General practice has really transformed in this regard. But I would just say that for secondary care, I hope we never go back to the previous outpatient model where thousands of patients would travel to a hospital, wait for 3 hours, simply to be told a hospital test result for a follow-up appointment. We just need to not go back to that, because it's not just about doctors, it's about patients, and it's just right for them not to be having to be so inconvenienced and having so much of their time taken away simply for these processes that we used to conduct. And if there's something I don't think we've yet done, but we must do, is just break down the barriers between primary and secondary care and work as one system. I certainly think that NHS IT has been highlighted. We've got too many GPs who are constrained, and in hospitals with Windows 7 computers. We don't even have webcams. We suddenly now had to try and get hold of more equipment, but let's make sure we're fit for purpose. The investment will be more than recouped by the productivity that we're achieving. So let's just make sure we do that. In terms of patients, I think what's really come out of this is how technology should benefit patients. You know, the fact that we are now delivering oxygen probes to patients just shows this is what we need to be doing much more of. I now no longer have to see patients coming to the practice to have their blood pressure taken. We should just give all our patients with hypertension home blood pressure monitors. It's cheaper than 2 months worth of an antihypertensive prescription. So we need to really capitalize on patients also being empowered and having much greater access to healthcare rather than the traditional messages. I think we've also learned that some of the historic structural and cultural inequalities in the workplace have come to light. With the BAME doctor issue and healthcare worker issue, I'm sure there are many reasons why, but one of the factors that we've highlighted for a long time is the fact that doctors from the BMA's own surveys from a BAME community have reported higher levels of bullying and harassment. They have reported that they don't feel as comfortable to raise concerns about safety in the workplace, and they're not as willing to speak out. And 3 times as many BAME doctors told us in a recent survey that they have felt under pressure to see patients without full protective equipment. And I think we just need to bear in mind there's something about what we've learned from that. With regulation, CQC, we heard that at the beginning. I called for a suspension right at the beginning, but we really can't go back to that process of weeks of a hospital taken away in preparing for a week of being monitored. And then after that, you go back to your old ways. This is not a way of quality improvement. Other nations in Europe don't do this. And I sincerely hope we replace this system of CQC regulation with one of support and quality improvement. Of course, you've got to have some sort of regulation, but let's learn from other countries. Let's not just go back to that. And the same applies to the systems of appraisal and revalidation. They've been put on hold. I don't believe that the medical profession is any less safe. So let's learn from that and don't go back to the past. I also think we've learned interdependence. We have learned how doctors, nurses, and across different specialties have worked together. Doctors have innovated, they've redeployed themselves, they've learned new skills, and we can do that. So let's not go back into the old ways of working. But also it's taught us about the interdependence between doctors and also people working in the community, the carers that go and see patients to allow them to stay at home, those who are shielded. And we are part of one big system of health and social care, and including the care homes. And I hope we recognize that and we pay tribute to the work that we all do as part of one interconnected team. And that is how the NHS and social care system needs to be for the future. But I think the other thing this has done is also highlighted, and just today I was thinking about how we as a profession are concerned about issues around inequalities and social determinants of health, and our responsibility for a better, a more equal society. And the ONS figures yesterday, which show how some sectors of our community are more affected by COVID-19 because they're actually security guards, because they are bus drivers, because they actually have to drive taxis in close proximity to others and haven't been protected. And that, of course, affects us as doctors because an unequal society has a bigger impact on our NHS. And I hope that that whole sort of dimension of a fair society and addressing a lot of the inequalities is also addressed as part of the way we move forward. So thank you very much for allowing me to speak today.
Chaand, thank you very much indeed. Always good to see you, and thank you for joining us. We're now going to segue slightly because your questions and comments have been building up and building up, which is fantastic. We've invited 2 or 3 people, as it were, not in charge of the Royal College of this or the BMA that or what have you, but people are out there doing it as well day in, day out. And I know all of the senior figures are as well, to give their snapshot on what they've heard so far, what their own experiences are, and also I'm going to put some of your questions to them. And the first we've asked to do that is Dr. Joel Meyer, who's a consultant intensivist at Guy's and St Thomas's. And his fingerprints are all over a development in virtual visiting to try and deal with some of those problems. So Joel, good of you to join us. What's your take so far of where we are and what we're hearing?
Thank you. I'm just going to try and share my screen here if possible. Do you have some slides?
Yes, I do.
And does it look like gingerbread men?
No, looks like a list from your documents file.
Let's try that. There you go.
Gingerbread Ben. Over to you, sir.
Right. Thank you. So intensive care has been rather emotional for the last 7 or 8 weeks, and it's nice to have a moment just to pause for breath and to hear some of the forward views. I think it's important to just point out that intensive care is not just about responding to critically unwell people who present as an emergency, but also we're an infrastructure service for all of the surgery, radiology, procedures in cardiology, transplantation and cancer care that needs to happen and that has been put on hold. But I really want to just start with an example of an ultra rapid COVID response project, which simply would not have been able to happen in business as usual. And that's the Lifelines project, which began in intensive care 7 weeks ago with the realization that visiting would be banned or at least heavily restricted, and that patients on ventilators wouldn't have their family by their side, which is just the norm in intensive care. And so together with Professor Louise Rose, who's my sort of co-founder in this project, we set about trying to work out if we can use some off-the-shelf apps to connect patients with their families on sort of iPads, but unfortunately it just wasn't feasible to get nurses able to log into ordinary apps. So we pushed ahead, linked up super rapidly with an app developer in Atonics. We contacted the tech companies and we found a sort of host partner and a charity, and within the space of 3 weeks we had deployed over 1,000 4G enabled tablets across the nation to all 4 corners of the nation to facilitate virtual visiting, which seemed like an age, but it was actually an instant in the sort of timescales that usually require this kind of work to be done in business as usual. So I just want to point out that the partners involved were BT, Google, King's Health Partners, and they worked super fast, and they just responded to the idea that we had to be ultra rapid and agile. And so it's been an example of what can be achieved when clinicians and academics and industry and charities all pile in together and innovate and spread at a real pace. And it's changing the way we're thinking about tech within ICU, obviously. And now there's a few other things I want to point out in regard to unlocking the NHS, because GSTTs in South London, and South London was at the heart of the national response to COVID in terms of numbers, and GSTT, Guy's and St Thomas's, are at the heart of South London. So some things have happened there in the last 6 weeks that I think will help us unlock the NHS. First of all, there's transparency of data for the first time. I mean, I would never have had this kind of graph given to me in normal time, showing me the activity across all of South London intensive care units day by day. And that's so informative when you're trying to work closely between teams and coordinate yourselves. Another South London project is this Sprint service, which is a retrieval service which allows patients to be transferred safely when they're on ventilators or very ill between centres. And it's been in the planning for 2 or 3 years, but of course there's opposition and risk adversity. And now in the space of 5 weeks, 164 transfers have been done by those teams with COVID patients on ventilators. And now we're talking about a national standard for inter-hospital transfer, again in the space of 4 weeks. Then we've got the response to rehabilitation after intensive care, which I think Alison alluded to, and I just want to highlight it because this has been an underfunded part of care forever. In fact, it's not funded, and yet people are doing it seemingly out of goodwill because it's needed for patients. And now we're able to respond in this way quite in a coordinated fashion, knowing that we've got a greater scale than previously to address. And we can transform the recovery and rehabilitation for ICU survivors, working with the general practitioners, the community services, and revamp the tariffs that just ignore this side of care for intensive care. So we can now build in, hopefully, given the national view, some money to deliver this and embed it sustainably. And then I think the last thing is that...
Is that the last slide?
Yeah, the last point is just that...
Yeah, no, because I've got a couple of questions I need to put to you from participants, and I'm sorry, I just wanted to double check.
Yeah, it's my last one, and it's just to say that the real unlocking factor for me is that the public understanding of what the NHS and particularly intensive care is about and what it can and can't do is a huge key unlocked, because it's a finite resource, everyone knows that, but they've seen how we've been able to respond fast and how an entire health system can be repurposed. And we've got visibility now and realism about what treatment can deliver. So I think all these examples just show that there are assumptions that these things are already in place, and none of them were. And during the space of a few weeks, we've found the energy, the money, and the speed to get them in. And so that's normalization of care, not really advancement of care, due to a backlog for 10 years.
Sure. Can I ask you one thing that's cropped up from a number of people, and that is how technical innovation, online utilization of iPads and stuff, which you demonstrated there, can be impersonal, the degree to which you have to take those patients, particularly in your area, adult intensive care, take the patients with you, or is it top down? This works better for us, therefore you will be able to work with it, or do you share with the patients as well?
Oh, it's very much a patient-centered activity. Obviously, nurses in intensive care are absolutely focused on both the patient and the family together. So the project's been about connecting families in the way we always have, which is to invite them in the intensive care units, participate in care, get involved in advocacy for recovery. And so the technology just enabled that.
But if we're to embrace a lot more of this, I mean, another couple of people have said there's a real danger that remote working is very impersonal. If you're operating as a surgeon on somebody who's under general anaesthetic, maybe that doesn't matter. But if you're doing other things like Nard was talking about as a GP, then remote working can be impersonal. How concerned are you about that as a clinician?
That is a fair point. And I suppose classical medical teaching would always have had us do face-to-face consultation. But in the space of an instant, our follow-up clinic for intensive care has gone virtual because it's had to, and we've actually, because of the nudge, realised how sort of unbelievably practical it is. There are a couple of disadvantages regarding examining patients, but we can get around that through some face-to-face clinics too. But it's scaled up the efficiency enormously.
Brilliant. Great presentation and fantastic observations there at the end. Joel, thank you very much indeed. Stay there because people may want to come back to you. Next is Husein Mawji, who is a general practitioner. Perfect. Same thing, short and sharp on your general observations, if you would, Husein, but then I've got some very specific questions. Lots of stuff coming in about the GP role having to be redefined, and that build-up of stuff that you've not been able to deal with because of COVID-19, and stuff that you've ended up doing that you didn't used to do because of COVID-19. That's just a taste of what folk who are listening to the conversation are talking about. But over to you, Husein.
Thanks, Alastair. So the first thing I want to say is that my experiences represent what we've done in Nottingham and Nottinghamshire, but I expect to be replicated up and down the country by general practitioners everywhere. So our first challenge, as has been previously noted, was to reduce footfall within practices. And virtually overnight, all practices adopted a total triage model of assessment, with patients seeking medical advice being booked into telephone or video consultations. And within Nottinghamshire, we saw within a fortnight, 120 out of our 130 practices routinely offering video consultations with patients, using secure clinical systems and software to prescribe electronically, to issue sick notes, to issue patient advice leaflets, all digitally directly to patients' mobile phones. And as a consequence, most practices saw their footfall reduced to a mere handful of cases per day, while still being able to attend to their needs. And this has also allowed GPs who are self-isolating but well enough to work to continue to do so remotely from home. And I appreciate in some parts of the country there have been issues with access to the tech to do that. But I think in great swathes of the country that has been addressed and continues to be done. The second major challenge in Nottingham City was we needed to generate capacity for an expected huge surge in cases and deaths, which, when we were discussing this in late March, was predicted as being a spike in mid to late April. And it was evident that across much of general practice, we would be unable to cope with this from an infection control point of view. In Nottingham City, we estimate up to about half of practice simply couldn't manage hot and cold patient flow. So we identified two large existing premises, both of them lift buildings, and by collaborating with the other system partners who were using those buildings for services, we're able to evacuate them to other sites and rapidly develop hot hubs, which I appreciate have been developed in many other parts of the country, where patients who had symptoms of COVID and who after rigorous triage were felt to be sufficient as well as to need face-to-face assessment could still be referred to and seen. We had to undertake some very minor premises work. We developed really carefully constructed standard operating procedures, reducing risks to clinicians and the admin staff and to the patients that were coming. We worked very closely with infection control and public health with this. And as has happened across the country in many places, these centres were operational within days of us identifying the need. And in Nottingham, they've seen several hundred patients. And core to their success has been really two things. Firstly, collaboration between dozens of practices. All the clinicians and staff who worked at the hubs in Nottingham so far have done so without additional payment, usually on days when they would usually have worked at their own practice. And I appreciate that this is a contentious point across the country, but certainly that's how we've managed it to date in Nottingham. And secondly, a city-wide mentality of rigorously triaging patients to ensure that only those who really genuinely needed face-to-face assessment were brought in, but those patients could be brought in for that face-to-face assessment. And then in tandem to the centres, we developed a city-wide COVID visiting service that all practices could access, staffed by the GPs in our extended access service in collaboration with a local black cab firm. The taxis lend themselves brilliantly to this purpose. The driver is separate from the clinician due to the Perspex screen and is thus protected. And the GP has a large area in the back of the cab to store and don PPE and other equipment to write up the notes for patients. We were really fortunate in that we were offered free of charge some logistics software by a developing company that meant that we could ensure that the visits across Nottingham City were undertaken in an efficient manner rather than the cabs crisscrossing in a fairly haphazard way. We've operated with 3 to 4 taxis a day to date, but there's capacity to upscale that if needed. And then finally, and I think this is the really critical bit that all of our partners tonight have alluded to, we have collaborated in general practice hugely with all of our other system partners. You know, we've had a fantastic relationship with our community nursing provider, who has been massively supported, and we had conversations when the surge looked to be huge about how we could share our nursing workforce between general practice and the community nursing workforce. The City Council has been particularly supportive across managing the COVID centres, and also in contacting and supporting shielded patients in collaboration with the social prescribing link workers that we now have within our primary care networks. Public health has been brilliant at starting conversations as to how we can be supported to ensure that immunisation programmes and other activity can continue. And we've had several meetings daily between these providers, but also the acute hospital trust, the mental health care trust, community and voluntary sector. And these collaborations as part of our Nottingham City Integrated Care Partnership will be central to how we move forward into the new normal within primary care, managing a tripartite model of care, which includes a steady stream of hot COVID positive patients, returning to business as usual but socially distanced general practice whilst maintaining rigorous infection control, and then the management of our housebound and care home patients who may or may not have COVID and who may or may not be shielding. And we'll want to ensure that we embed all these new models of care and these partnerships in the future. So that's my whistle-stop summary. There are lots of other bits such as OPEL reporting, as Joel.
No, that's brilliant. One thing that somebody specifically wants to ask you, post-COVID-19, then regular, as it were, things that a surgery, even a city alliance of surgeries, as it were, would be doing, is more blood testing, more swabs, more vaccination work because of the post-COVID-19 echo. Are you able to give that some thought whilst redefining what you do at the moment, as it were?
I think it's a very valid challenge. And one of the keys that we will have to ensure is that we are enabled in a collaborative and system-wide way to give patients access to testing, swabbing, blood testing to support the recovery. And actually, I think in areas where primary care networks have developed a certain level of maturity, or GP federations and collaborations with community nursing partnerships have developed, we will be ahead of the game in being able to organise that. So I think collaborating.
Doing that stuff with the Royal College of GPs.
Well, the Royal College of General Practice, I think, is very supportive of the primary care network model of care, but the main bit will be the local nuancing of how we can practically do this in a manner that respects social.
Just because Martin Marshall said, you know, research papers being fed through to the centre is really helpful. So exactly as we said at the beginning, you know, if Nottingham are doing brilliant stuff, then within 6 months we want everybody to be doing equally brilliant stuff.
And certainly we've seen a huge amount of sharing of innovation, expertise and experience. The primary care WhatsApp groups have been on fire for the last 2 months. You know, the amount of sharing of information, the support that we get from the BMA, the sharing of information from Nikki Kinani and Ed Waller and various others from NHS England, who I appreciate have a really challenging job. But for those people who are innovating within their boundaries, I think it's really important that that's shared and that we learn the lessons in the future and take these new models of care.
I think, but again, apologies, this is brilliant stuff, but again, because of the clock, I'm going to put the same question to you as I put to Joel, because it's come in now from quite a lot of people. How do we include patients in this process that you're describing? I.e., again, one of the greatest charges that's ever made of this brilliant profession that you all represent is it's too top down, it's not enough bottom up. So whether you're redefining general practice or hospital consultation, even somebody said earlier on, redefining the bedside manner, as it were, how do you involve your customers, the patients, your clients, the folk that you care for in that process, rather than saying, hey guys, this is how we're going to do it going forward?
So that's absolutely right. I think the challenge is in incident, where we have been for the last 6 to 8 weeks, it's very difficult to engage with our patients and our citizens in a meaningful way when we're all running around very, very quickly, working very hard to modify our services in a way that deals with the incident. But now that we're coming beyond the incident, and I appreciate we're not out of COVID yet, now that we're coming out of incident, I think we do need to very much ask for an evaluative set of feedback exercises with our citizens, with our patients, as to what has worked well for them, what hasn't, and that needs to be an important part of the jigsaw as to what we would put forwards moving forwards with models of care into the next 5 years. And I have to say that, you know, the relationships between patients, between system providers, has moved forwards, I think, 5 years in the last 5 weeks. It's been inspirational, the rate of change.
Okay, brilliant. Thank you so much indeed, Husein. And again, do stay for as long as you can, because we're moving towards the last few laps, and then we're going to have a much wider series of questions from folk, and you're all free to chip in. 2 more contributions before we get to that point. And the first comes from Toby Garrood, who's a consultant rheumatologist and clinical director of specialist ambulatory services at Guy's and Tommy's. So Toby, over to you.
Thank you. So I'll give a really quick overview of my personal reflections, having helped to lead the outpatient response at Guy's and St Thomas's. GSDT usually has around 1 million outpatient appointments a year, so it's been a pretty challenging time. And I was going to just talk a little about the nuts and bolts of what we've tried to do. Of course, we had to cancel a large number of appointments to support the frontline response, so we could deploy staff with the right skills and also cope with what was initially substantial staff sickness. And I should say I was struck by the enormous flexibility of staff and the willingness with which they went off to support colleagues elsewhere. It really was extraordinary. But what we've managed in the last 8 weeks is to deliver much of the long-term plan, which initially tended for over 10 years. So it's been pretty extraordinary times. So as we started to cancel appointments, a key thing for us was risk assessment, both at the individual patient and at service level, to make absolutely sure that we were minimizing risk of harm to patients. And we've built in some very strong procedures around how we do that in a sustainable way. Of course, as we've heard already, there's been widespread adoption of non-face-to-face appointments and means of communicating with patients, which have been adopted by absolutely everybody, and everyone's embraced it with enthusiasm. And we've learned that a lot of patients who we were sure we had to see face-to-face every time, we actually can manage very effectively through other means. But a key thing for us has been managing patient expectations. There's considerable anxiety in our populations, and as soon as it started, we were very quick to make sure that all means of communication, including our websites, were updated with crystal clear information about what patients might expect from us, and making sure they could contact us easily. A key learning for us was FAQs. A simple thing like that on the website in some areas resulted in a halving of calls to helplines. So it's a really important thing to do and keep them updated. Across many of our services, we now have online booking for helplines, so patients can go to a website and book a call, and they will get a call back within 24 hours. So as we've de-escalated face-to-face appointments, we've made absolutely sure that patients can access us, can access us in lots of ways through many channels. And similarly for GPs, we've now rolled out systems whereby GPs can almost instantly contact a consultant at pretty much any service for immediate advice, and that's something which we hope will survive into the longer term. So as we move into the stabilization phase, we're quickly but safely trying to increase capacity and get our patients back in again, whilst knowing that there may be a change in external circumstances and may once again need to respond to further surge in COVID. So we're prepared for that. But it's also been really important for us to make sure that our patients know that we're here, we want to see them, we want to hear from them, we're available, because a big concern has been our patients have been frightened to come to hospital and assuming we're overrun, but actually we're here and we're ready and waiting for patients to get in touch with us. And we're also using the current headspace we have, such as it is, to evaluate what we've done. We've done numerous interviews with consultants and got a lot of patient feedback to really understand what's working, what isn't working, what do we want to keep, what we don't want to keep, what we're doing at the moment, and what have we lost, what were we doing before which was so important we want to get back again. And important to all of this is the patient voice, and we're making absolutely sure we understand from patients what's working for them, what their experience has been. And another really important thing for us has been building tools for prospectively assessing risk, so we can look at our patient populations and make sure we know who's at risk of falling through the cracks, and we can prospectively contact them and make sure they're okay. So as we move into recovery, we are looking at how we redefine how we do business. Lots of people are doing lots of really exciting things in different ways, but it's important that we ensure there's a bit of homogeneity around that, and we start to codify the new ways of working in the pathways and ensure some consistency. And these are enshrined with key metrics of performance and ensuring that we know we are doing what we think we're doing in a way that delivers good patient outcomes. A really interesting thing in outpatients is how we've moved from very scheduled models of care. You will come at a particular time to much more flexible models. So patients can contact us when they're flaring, and we can see patients when they're at most need and make sure we see lesser patients who don't need to come and see us. And I hope that we'll keep a lot of that in our future ways of working. And also really important thing.
I'm going to butt in, only because again time, but there's a lot of reaction to this, a lot, that last bit particularly that you were doing. The first point that a couple of people have said is, have you just done all of that off your own bats as a department, or have you been blocked down by bureaucracy or monitoring, or let's see if it works or what have you? Because like many of you, you've been doing revolutionary things, switching to non-face-to-face appointments, etc., much more use of video. Did you just do that?
Well, we did, but it's largely because the driving force was we got to keep our patients safe. So we had to do everything we needed to do to keep patients safe. But we are
Camilla
now.
Cavendish at the beginning described the NHS as operating in effect as a kind of UDI. All of you are just getting on with it now. So does that mean that bureaucracy is, it's crying wolf almost? You say, yeah, we hear what you do. Actually, we know what's best for our patients. We're sharing that logic with them, and we are getting on and doing it.
We are. I think we've been through something of a honeymoon period, and I think that
you fear it'll stop when COVID-19 is allegedly over.
I think some of it might start to creep back, but it's not all bad. It's really important that we are evaluating and measuring what we're doing and making sure we're doing it in a sensible way. So I think
people are also saying to me in the question flow is that you've done brilliantly, as indeed has Husein in Nottinghamshire and the rest of it. So when it's all over, the bureaucracy will reclaim its control, and either it'll say, "Oh, you're doing that's absolutely brilliantly, so you'll need 2.5% less next year because you've done so well with what you've got at the moment."
Well,
I'm just saying that's what listeners are saying.
We will be a lot leaner and not more efficient, I think. But we now know that a lot of that bureaucracy didn't necessarily need to be there.
How interesting. So real savings can be made, but there isn't a barrier, as it were, to you making those changes that you wanted to make in the same way that Husein wanted to as well.
Yeah.
Do you agree with that, Husein? Can we have Hussein's volume up?
I'm sorry, Alistair. I was answering a question in the chat and I didn't catch it.
Absolutely fine. This is that's what it's supposed to be like. Very, very quickly then, because otherwise I'll be shouted at by the bosses for running over. What was really intriguing there from Toby was, like you, he described, as it were, a brave new world in his bit as a consultant rheumatologist, and he asserted that basically they just got on and did what they knew to be best practice. The patients were content and were consulted, that bureaucracy was less of an impediment, and that they themselves were able to monitor outcomes as well as tinkering with the inputs. And I merely say, is that your experience in pretty well revolutionising the collective of GP offer in Nottinghamshire?
I think we've been given fairly free rein to do an awful lot within our practices. I think it's difficult when we then have to look at what services we'll offer longer term. Clearly, the commissioners have a statutory obligation to ensure that we're providing services that are both effective and functional. So there is a balance here of us showing the clinical leadership and innovation.
So one thing that needs to come out of this conversation very clearly then, which is, again, and I tried to make it clear at the very beginning as well, it isn't only the medicine, as it were, that folk are talking about, but it is that managerial organizational methodology that needs to be redefined. And I think Camilla Cavendish set some targets about that at the top, but that does need to be rewritten rather than just ignored.
Well, I think what we've seen from all the panelists, and has been mentioned by several people in the chat and the questions, is that when clinicians are asked to step up to the plate, they generally are very, very good at finding solutions, creating innovative solutions to the issues that we have. And clearly there has to be oversight of that by our commissioners and by NHS England. But if we allow senior clinical leadership to innovate with grassroots clinicians on the ground, but also in the future encourage new clinical leaders to come through from all backgrounds. I think there's a question in the chat about diversity. We need to encourage everybody to come up and step up to that plate.
Fine. I'm going to stop you there again because of the time, but I'm really grateful to you for rejoining us on that conversation, Husein, and Toby Garrood, I beg your pardon, utterly brilliant. Thank you all very much indeed. Final bit of this sort of bit, which I hope you're finding useful, building upon what the Royal Colleges and the BMA had to say, building bricks, as it were, is Richard Brady. Now, he's a consultant, colorectal surgeon, also digital lead, though, for the National Institute of Health Research, and is from the northeast of England and North Cumbria, and is Executive Communications Chair for the European Society of Coloproctology as well. Richard, your few minutes.
Thanks very much for the welcome, Alastair. Given the time constraints, I will focus very much on the presentation. I hope, given the digital lead, you're able now to see my screen. Let me know if that's the case.
Yes, I can see you, but I can't see anything you're trying to illustrate with.
Okay, hopefully that's it.
We can now.
In order to explore the issues that are relevant to the generality of general surgery and surgeons in the UK, I thought we'd just wander through the patient flow pathway and how it's been devastated by COVID-19. The first is that our input, or the referrals from GPs and A&E, has been devastated overnight. Those numbers are down massively. We don't quite understand where the initial presentations went, but now we are seeing the results of more complex diseases presenting further down the line. Part of that was patient fear and anxiety, them not wanting to bother the NHS, and some confusion about when and where to present to. Tertiary referrals from other clinics have obviously dried up because they have the same problem, and we feel that there's a tsunami of cases building up in the community with deteriorating and advancing pathology. Outpatients were cancelled or deferred because of a requirement to reduce physical contact, and that meant that we couldn't progress patients through the NHS system. MDTs, which helped us with complex decisions in surgery, were cancelled or restricted, and key staff were redeployed to other agencies and other places in the hospital to help with COVID. Investigations such as endoscopy and radiology were reduced or cancelled, partially because some of them were aerosol generating. We wanted to reduce contact with patients with the healthcare sector, and therefore patients got caught in a holding pattern with a requirement to be investigated but not being able to progress through the system. Alternative management options were used, such as chemoradiotherapy in some cancers and esophageal cancer subtypes. Antibiotics were used to treat some episodes of appendicitis and drainage. An old cure was used for gallbladder problems, diverticular or bowel problems, and appendicitis, leading to generally more complex conditions when these patients present subsequently for surgery. We also had limited surgical access and critical care restriction because of redirection of resources. And we underwent a reevaluation of risk versus benefit of surgery, partially because of evidence that was emerging from China and Milan, but also COVID surge. The rapid introduction of research during this process demonstrated that those that were positive with COVID and underwent major surgery had a 28% 30-day mortality and an unacceptable risk to most surgeons. There's also a limitation due to staff redeployment in the theatre setting, with anaesthetists, assistants and theatre staff being absent due to illness or isolation, and therefore personnel problems. There are also additional considerations to surgical protocols, new vetting panels which prioritise patients, new preoperative screening processes, a limitation of minimal invasive surgery, and reduced case turnover in theatre due to the requirements of cleaning air and other PPE requirements in theatre. So that led to less flexibility and less efficiency. Following that, then there was additional cures or highly adapted solutions introduced by the surgical fraternity due to this ramping up period that occurred after the initial pandemic peak. There was a GP and public health campaigns encouraging people to get in contact. Email referrals were encouraged with our GP partners, and a proactive approach has been taken in secondary care to contact GP surgeries in order to inform them that the service is open for business, with a focus on public confidence. Outpatient access has now almost universally become video or telephone conference. This is efficient, fast, decisive, and also very flexible for patients and surgeons, and demonstrated that surgeons essentially who knew were adaptive to new technology. Investigations such as review and prioritization of our investigations has been undertaken, and we've restarted MDTs or multidisciplinary meetings in the era of COVID via video conferencing. We've now reevaluated the initial fears and risk-benefit ratio after changes were informed by research that has been produced both by COVID surgery itself and other institutions around the UK, such as Oxford and the Royal Marsden, which have produced good research to suggest that if you undertake operations in a cold centre, your mortality rate is essentially the same as it was pre-COVID. So the key here is the operating environment. We're looking to increase cold sites, COVID light operating and mobile units or private sector units or cold hospitals. And additionally to that, we're using cancer referral hubs in some areas via cancer alliances to pool cases together so that they can be operated in designated cold sites with ring-fenced resources. The vetting panels that currently exist are very important because they help us with prioritization and the ethics of this condition, which are very complex. And surgical conditions such as minimally invasive surgery with a reduced stay have now been reintroduced in a lot of trusts across the UK, leading to increasing flexible working by surgeons and increasing innovations within the operating theatre. The consent and decision-making process has been overhauled completely, with major consideration of COVID-19 vulnerability in our patients as a key aspect of consideration. So what are the required solutions? How do we hear and spread about these successful innovations? Well, part of this panel has raised many solutions to that issue. What are the alternatives to traditional referral and investigation pathways? How do we deliver training, which has been devastated during COVID-19 in a restricted post-COVID era? How do we increase theatre and surgical efficiency and the real estate of operating potential? And what technical and device solutions exist to increase staff safety and reduce viral contamination? How do we discharge patients faster and avoid critical care? How do we provide informed consent, and where are our decision-making tools with data which is up to date from the day that that decision is made in the region that that decision is made? And how should we screen preoperative patients and staff, and how often? The second issue is that we may not be over this completely, and if a second wave arrives or if variable outbreaks across the country develop, when is it appropriate for healthcare sectors to healthcare institutions to reinstitute local recovery phase again? Many of these questions are not answered. Many of the questions we're looking for a solution, and I'm delighted to take any questions.
Absolutely brilliant. I've got one that's come in from somebody, and you mentioned your European experience there as well. But somebody specifically says, you know, in terms of the sharing and the learning, we've seen different rates of success in containing COVID-19 in places like South Korea and Germany. But are there also operational lessons that we can learn from how various disciplines operate within those countries too? And are there papers that you would direct people to?
So I think in this day and age, papers actually delay the dissemination of information. One of the key aspects of the surgical community is how connected it is, both in social media and its ability to get in contact with each other via video conferencing. And most conferences in surgery have now been completely converted to online platforms. And what we are hearing is the cutting edge experience from places like Wuhan or Milan as it occurred. And as part of the European...
Well, just to say, I mean, WeShare.Healthcare, which is behind this whole conversation, that's exactly what we're trying to focus as well. But your hands-on experience is, as it were, that there would be a volume of traffic that colleagues could share and benefit from.
Absolutely. This pandemic has increased the contagion of dissemination of innovation across the globe. It has become contagious in terms of communication. People are interested about others' experience. We want to learn about the lessons from other places. And absolutely on the ground, innovations are being used across the globe when centres develop good techniques, cheap techniques and efficient techniques for dealing with this crisis in their own patients.
Okay, I'm very grateful for that. It is now 9:24 and we are due to pull the plugs upon the entire conversation at 9:45, well, 9:40 with just a quick tidying up from Peter Kalu. And you have been inundating me with questions. The way this is going to work is no names, no pack drill, but I'm going to go through a number of questions that have come in. I may throw it to a member of the panel, or if you want to come in on it, then by all means do. And the first question, and it's my version of one that a number of people have put, and I'd like Christopher Moran to have the first stab at it. And the question is simply this: can clinicians really lead the health service?
He's gone on. He's gone.
So Christopher's had to go. Is Camilla still with us? I know that Chaand is.
Yes, I am. I am still with you. I've just gone dark because the sun has set. Sorry.
Is, can clinicians really lead the NHS? Is that going to be allowed to happen?
I think it's a brilliant question, and I wanted to ask actually the panelists what they think the role of managers is, because we haven't talked at all about managers, and you know, over many years I've heard good and bad things about managers. It's always seemed to me, and there was a wonderful woman who had been a nurse who used to lead QE2 Birmingham, and she used to say, you know, if you keep running stories in the press about how awful managers are in the NHS, we'll never be able to hire the brilliant people that we need. And actually, I do think that's true. And I think actually QE2 Birmingham was a really good example of a top team that lasted for a very long time, worked together for a very long time with clinicians and managers working really closely together. So my view is that that's what works best.
Okay, well then let me
when you say whether they'll be allowed to, this conversation makes me wonder who's in charge.
Only because of time, because you made two very good points there.
Yep.
Chaand, Nagpaul, do you believe, bearing in mind what Camilla was just saying, that there are good working examples, particularly post other crises, that the way forward is not only that clinicians should lead, but they will be allowed to, and structurally it will happen?
I'd like to say that clinicians have led, it's not they can, they have led. The GP clinical systems, the IT systems were developed by GPs back in the 1990s when no one was interested. It was GPs who created an electronic health record and started to consult with their patients with computers they bought themselves. And those systems are now mainstream. They have led the way. We heard from Derek Alderson around innovations in virtual technology for surgery. We have e-consultations have been developed by doctors in primary care. And the same, I think, is the case for all healthcare professionals. We need to be allowed to lead, but we do need to work with managers as well. But we are innovators. You heard today from so many innovators. We have been built that way. That's the way we were trained, to actually innovate, make decisions, think ahead. And if we're free to do that, I think the health service will benefit immensely. And this is the time to do it.
William Harrop-Griffiths, you said in your contribution, quotes, the old system is just not going to work anymore. So do you go beyond hope to the practicality of saying, yes, that there, not only does there need to be a better future, but we collectively will be allowed to do it?
I think we absolutely have to be allowed to be a fundamental part of that process. We've just talked about the involvement of managers. Managers have to be involved, but I completely support Chaand in saying that clinicians and nurses and other healthcare workers are absolutely at the basis of driving forward the innovation. We have had tremendous experiences in the last few weeks. We need to use those experiences to create change in what we do. The old ways of doing things are the old ways. We're going to have to build new ways, and we all have to work together. We cannot have one group leading. We have to all work together, come together, and create those new processes.
Does anybody else on the panel want to come in specifically on that? You don't have to. The clock is against all of us, but those were quite constructive answers. Another question I've got here, and I'm going to ask Ryan Kerstein, who's one of our event organisers, as it were. Ryan, are you still online?
I am, yeah.
Okay, so you're behind WeShare.Health, and that's about clever ideas and pooling papers and what have you, but you're a plastic surgery trainee, so you've not got to the top of the tree yet. What a lot of people are asking is, how do trainees get involved as well? How do these brilliant young men and women who are studying medicine and are halfway through, some of whom have, like in Bristol University, I remember because it was my own university, rushed through and what have you. There's a real appetite in the audience listening to this conversation of saying, how do we bolt in the youngsters sooner rather than later as well to this brave new world that you've all been talking about?
I think that the acceptance that ideas can come from anyone is definitely taking hold, and just because you're at the top of the tree or at the very start of it, it doesn't make any difference. If you've got a great idea from a background you've had or an experience you've had, then it's just about finding the people that will help you take that forward. And we've heard on this conversation, there's been amazing innovators from very, very senior to less senior. And so find the people that get it, and talk to them about your ideas, your experiences, and as a team, you'll kind of be able to work forwards together. But we definitely shouldn't be looking at just the top of the tree in terms of being able to deliver those innovations. Literally anybody with the experiences that they're able to pick from past life, past jobs, etc., is going to be hugely important.
Alison, Pittard, any thoughts on that?
Yeah, I think it's really important that we change the way that we work going forward. And like I said in my presentation, it's not about who you are and what your title or your label is. It's what you bring to the team. And if we look at what the service requires, what patients want us to deliver, and then work out who has those skills and that experience, then we all work together. And that's how we've been working, certainly in critical care during COVID. It's worked well. It's been stressful for people because they're not used to doing it. But actually, once they've developed that competence and that expertise, then people have thrived, and we need to hang on to that going forward.
I'm grateful for that. Anybody else want to come in other than those that I invited to? If not, I'm going to another question, and this is quite a democratized conversation. I want to be clear about that. So the people who are guiding me are saying, look, heck, a lot of people are banging on about X, Y, or Z. One thing that's cropped up time and time again, and a number of you spoke about it, is Black and ethnic minority issues, not only amongst the people who are suffering COVID-19, but also all of you well know your own colleagues from a Black or ethnic minority group who are potentially greater victims. What folk are worrying about is that once the crisis abates slightly, all of that, oh yes, we must do so much more, will be forgotten again because we've then moved on. Chaand, does that worry you?
We mustn't allow this to be forgotten.
Do you fear that it might?
I don't, actually, because I will do everything I can, and others around here will do everything they can, because one thing we've learned is that the National Health Service simply could not have coped without this contribution. I do believe that the public and our colleagues all understand the immense contribution of our overseas and international workforce. And I think we've celebrated the fact we work as teams. We just heard that. And those teams extend to no matter whether you're of a BAME background or a white background, whether you're a woman, whether you're a man, whatever. It's broken down over those boundaries. And that's why I think we need to go further and look at embracing our international workforce in things like getting rid of the health surcharge, for example, and show we're a welcoming nation. And that, I believe this is the time when we won't go back. And I have some conviction and some belief in my colleagues and the public that we will not go backwards. I have to have that faith.
Derek Alderson, do you share Chaand's confidence?
I do. I think that it's an absolutely critical issue. There clearly is a problem that needs to be examined. We're desperately short of data, but one of the things that everyone has emphasized tonight is the fact that we can get information about COVID and COVID-related problems very quickly because people are genuinely interested and genuinely want to find out what's going on. So I'm with Chaand on this. I think that there's a strong sense of we must find out what this risk really is, and we must take measures to make sure that we don't get into this kind of mess again. The one thing I would say very quickly, Alastair, from the question before, is one of the things that really has become obvious in this crisis has been the breaking down of the hierarchical barriers, practices, behaviours that existed certainly within hospitals.
You also said in your contribution that the silos were out as well, that you all had to work collectively more wisely and send in ideas of how that best can be done.
Absolutely, yeah. Fundamental. We cannot go back to silo mentality. I hope that many people had cottoned on to that, but if they had not cottoned on to it before the COVID crisis, well, it certainly hit them in the face now. So it's become very obvious that...
Can I just bring, Jean Nehme, are you still there, Jean? I think I can see you there.
Yeah.
To what extent does what you've done, I know you're a surgeon as well, but forget that just for a moment, but the methodology of things like WeShare.Health, platforms of that nature, there's this great willingness at the very top of the professions, plural, to embrace change, to put clinicians to the fore, and yet not forget the patients and so on and so forth. Has it become easier for folk to do, the older generation who are running this great profession, or do we have to wait for younger people like you and Ryan to take over?
I mean, look, Alistair, I think it's going to be a team effort from everybody. I don't like to split people based on age. You know, I know Prof. Alderson pretty well, and I think he's got a lot more energy than me most of the time. So to be honest with you, I don't, fundamentally, I think, if you look at everybody right now, we're all sitting in the comfort of our own homes or in an office somewhere, right? At the end of this call, we're going to switch off, probably make a cup of tea, and then spend time with our family, which probably matters for a lot of people on this call, right? If you think about that experience that we've all just had, and then if you think about it as a patient where, you call in, you talk to your doctor, and then you make a cup of tea, and you don't have to spend 3 hours on a train or 3 hours in a car, try and find parking, try and struggle, right? We're not going to go back to the old ways, okay? I think people are realizing more and more so that just things being efficient is important, and it's not just for the patient, it's also for the doctors.
I like the optimism, but I also like your first answer to my bit of the question. I've got to bring Sarah Clarke in, because we've only got about 3 or 4 minutes left. At that vital point, Sarah, in your contribution, you said, like everybody else, no, we cannot go back to the old ways, but we need to pace change. There is a downside and a danger of rushing. Just expand on that for 30 seconds.
I think that everyone is very tired at the moment. I mean, the momentum is still there and people are working really hard, and there is that stress that's there. And I think to just follow this on with all this change rapidly is going to be welcome because people want it. But I think we have to pace it a bit, because I think too much and people will just tire too quickly. So absolutely up for it, and I think everybody's up for it. Everyone's up for it on the call, and it's fantastic to hear that. And we won't go back. I completely agree. None of us want to go back. And where there's a will, there's a way. But I think we just can't do it all at once, and we have to just prioritise it, give people a bit of a chance to recover, and take their breath, and then they'll be able to contribute better because they'll be refreshed. So it's not saying don't do it. It's just saying let's pace it and let's not wear people out too quickly.
All right, final question from me, and again, it's come from several people, and I suppose in a way it's addressed to all of you. It's certainly addressed to the NHS. Communications is a problem. The NHS itself has not communicated very well. That may be the government's fault. It may be Mr. Hancock more than the NHS, I don't know. But there is a perception from people listening to this conversation that the NHS has not been great at communications, but nor have you, as Royal Colleges, as leading figures and so on and so forth. And I want David Harkin. David, are you still with us?
Yeah, I'm still here.
Give me a final thought on that, because as an outsider, I've sat here and listened to a whole series of brilliant contributions and genuine commitments, and we know the methodology for sharing ideas or publishing thoughts about bright new ideas through WeShare.Health and all of that and what have you. But at the pounding heart of it, according to the people who've come online and submitted questions and comments, the pounding heart of it is still that crucial relationship between medical practitioner and patient. Communications.
I think communication is key in every sector around the world. And speaking from this, from an outsider in, and I think just giving a bit of perspective on it, I think leadership is outrageously difficult. I think it's a very emotional environment in every corner of every aspect of every office, hospital, home around the world right now. So I think there's areas where it's quite hard, and when people are in and not on challenges, it's really hard to take yourself out of it. And I think everybody will reflect when they come out of this, and as Sarah just talked, when people have an opportunity to breathe, how could we do this? How could have we done it slightly differently? But I think there's also a huge amount of pats on the back which need to be given.
Well, I'm going to butt in. I'm going to butt in because here we are on Zoom, and I've just had this brilliant comment, and then I'm going to ask you to draw your conclusions, and then I'll hand over to Peter. But how about this then? On the National Health Service, it is worth commenting that whilst we were de-siloing already, and our collaborations have been amazing, we must be allowed to continue to influence change rather than it being imposed upon us. i.e., do you know what? Don't beat yourselves up. Progress is being made, and maybe ventures of this nature can not only share good practice, but provide a platform for pooling it. Final thoughts, David.
I agree. I think Jean talked about earlier about entrepreneurship, right? We passionately believe that 7 billion ideas, everybody has the ability to change their world, whether it's the world, their office, what they work in. Tiny ideas do count. And I also agree with Sarah that sometimes you've got to pace it. Okay, but what you can't do is forget. And if I go back to one of the graphs I showed on one earlier about the Ebbinghaus curve, and the whole point of the WeShare is let's not forget what's happening, because it's very easy to forget when we move back to a brilliantly busy environment, and you're never not going to be in a brilliantly busy environment. So wholeheartedly agree with you, Alastair, and I just encourage the audience and also the panelists who've shared some extraordinary innovations and ideas, and just sometimes a snippet and then we've moved on to the next thing. We need to capture that. Take 90 seconds, visit WeShare.Healthcare, and I genuinely believe at least we will not forget some of this stuff, but we can act on it with much more of a better framework.
I'm going to get beaten up for saying that was the last comment from you before Peter, but I've just had a big lots of asterisks comment. Camilla, are you still with us? Camilla?
Yes, I am. Yes, I am.
This is something you mentioned right at the beginning, almost by way of your intro, and an awful lot of people are very keen upon it. You kind of implied that the health care silo problem really has been sorted. You believe that
No, I did not imply that it's been sorted.
That's what I thought. You believe it needs to be.
Yeah, and
otherwise an awful lot. Yeah, okay. Give me final 30 seconds on that, Camilla.
And by the way, I am actually acting as an advisor to the Department of Health and Social Care at the moment.
I think the listeners spotted that
in an unpaid capacity. So that is something I am obviously working on because I'm passionate about it. And all I meant at the beginning was that I think we've seen more collaboration. So in Greater Manchester, you've actually seen a central hub set up where effectively the central hub is paying for PPE, the hospitals are lending it to social care, and they're sort of recharging it. And just really pragmatic, intelligent solutions that are finally bridging the gap. But clearly we need much more needs to be done from government level. We need a proper settlement for social care, but we need proper integration. But I do think that will happen. I also think it will happen because the public have finally understood what social care is. For years, it's been impossible to explain to anybody what social care is. And I think the public have begun to see the importance of it and the need for carers. And I think that the mutual respect, I think we might be able to build more mutual respect between the NHS and social care as well.
And that bed blocking penny has perhaps finally dropped as well, because it was by force of circumstance. Camilla, great to see you. To my whole panel, absolutely brilliant. I mean, I think looking at my phone is almost burning here with stuff that people have pinged in. If I didn't ask your questions to the various panelists, my apologies for that, but we haven't lost any of it. This conversation's been recorded, and also the comments that you've sent in have also been curated, and this is just a start. It really, really is. And I hope you agree that it was quite a promising one. So thank you so much for joining us. And I'm going to hand over now to Peter Kalu, who has helped me throughout this whole process. And it's as much his baby as anybody else's. Peter.
Thank you very much, Alastair. It's actually been amazing just to see actually what's happened and the conversation that has happened. I never probably truly envisaged that things would be as good as it has been, as each of the panel members accepted the very probably bizarre request over the phone, wondering who the hell is this plastic surgeon asking me to attend a meeting. Thank you so much to all of you for taking part in what is hopefully a very unique event. I'd also like to say thank you, Alastair, for being an absolutely amazing host who's actually managed to whittle through as much as he had, with so many various prompts coming in from myself and Nadine in the background. So thank you, Alastair, for accepting the, thank you very, very much.
Pleasure.
I'd also like to just to mention some of the other guys who are in the background who you haven't seen. There's Max Stewart, Will Bolton, Ed St. John, Ryan Purdy, Marie Song, Philip Burns, who've all been in the background to actually make this event happen. And so thank you to you all. Thank you also to David Harkin and the guys at 7 Billion Ideas who've given us the opportunity to bring everything together. All I would now finally ask is that everybody who's been listening and has hopefully been kind of had their energy charged to try and innovate across the NHS, just take 90 seconds out as you now go off and prepare to go to bed and think, well, actually, have I adopted or have I done something different in my clinical practice? And is it possible that that change that I've made can help improve the lives or maybe even save lives? And if that's the case, then please do go via the WeShare.Healthcare website and actually add your contribution there so that others can review it and then others can adopt it if they feel that it's appropriate for you. So please, thank you very much for all joining us, and thank you very much for dropping by the WeShare.Healthcare website, and thank you to all of you for coming. Okay.
Good night and God bless.
Bye.